Thank you very much, and of course, I would like also to thank Arthur, particularly for inviting me, and you, the audience, for being here. It's always a bit complicated when your title really is not exactly as what is being introduced. So I was asked to talk about maintenance treatment and supportive care, and basically that's the presentation I prepared. I thank David for already covering the first part, but I will be rather brief and I'll just emphasize some topics that might not be extensively covered. Of course, we can talk about side effects of treatment, but then I should upload another presentation. Anyway, let's start and just briefly introduce the country where I come from. So, as mentioned, it's Belgium. It's not bigger than New York and its suburbs, but just to remind you, we, even being a small country, it's the capital of the European Union, and there's also a strong link between Belgium and Poland because the previous president of the European Union was Belgium and the current president is from Poland. The small country is maybe not known by its myeloma centers, but more popular maybe are some of the culinary aspects and that are known throughout the world. And I'll show you another one a little bit later in my talk. This is the university where I come from. It's the University Hospital Leuven, and this is linked to the Catholic University, where you can see here a glimpse of our rector. Now, coming back to the first part of the talk that I would like to rephrase with you, it's the maintenance treatment. And without going too deep into any type of philosophical discussion, I just want to reflect together with you on how do we define maintenance treatment, because sometimes, even at myeloma meetings, there is some type of confusion, because some people talk about continuous treatment, or should we talk about treatment of a limited duration? And we have already heard it in the previous presentations, 1 year, 2 years, 3 years. And basically, what is the aim of maintenance treatment? Do we want to increase the depth of response, in other words, to eradicate the MRD? Or is the best we can only to suppress it and to prolong, in that regard, survival? And then, of course, what is the optimal drug? But reflecting back to Professor Anderson's presentation, maybe what are the best combination of drugs to use for maintenance? Now, by definition, maintenance treatment is applied for a prolonged period of time with the aim of just preventing tumor progression. In clinical terms, it is in order to prolong the progression-free and eventually the overall survival of the patients. Now, we heard that historically there were studies with steroids, there have been studies with interferon. And for transplant and non-transplant candidates, there is also some difference maybe in interpretation, where in transplant candidates, it is a prolonged treatment after the transplant and preferably also after consolidation, where consolidation is a short-term exposure with the clear aim to improve the depth of response. Whereas in non-transplant candidates, it can be more considered as a continuation of at least one or more drugs from the initial treatment. And of course, the treatment should not be associated with too many side effects. Again, we heard about it. It's not anymore a question of being able to achieve the best response. In more and more patients, we are able now to achieve complete remission. And conventional CR can be, with the current triplets of drugs, be achieved in half or even more than half of the patients. But the challenge is to maintain the CR. And this slide, you have already seen it. So by maintenance treatment, we don't target the big part of the iceberg, we just target the lower part, what we can call in myeloma terms or in cancer terms, the minimal residual disease. And that's why the response criteria have been upgraded over the last years, where after the EBMT criteria, there were the International Uniform Response Criteria from 2006, and in 2011, terminology like immunophenotypic and molecular CR have been introduced. Now, it's always good to look around, to look not at your neighbor to say what does he or she have, what I don't have, but in terms of hematology, to look what's happening in other related diseases. And for instance, in non-Hodgkin's lymphoma, as many of you know, in low-grade lymphoma, rituximab maintenance treatment is routinely given after, for instance, R-CHOP induction for 2 years maintenance. Whereas in diffuse large B-cell lymphoma, it's still under investigation, the maintenance treatment. In some types of acute leukemia, you will agree, like in ALL or in promyelocytic leukemia, maintenance treatment is given for around 2 years. And in CML, which is from a biological point of view, a much less complex disease than myeloma, the continuous treatment with TKIs is given also beyond a level of complete molecular remission. And studies are still ongoing when you can stop treatment in those patients that have achieved a complete molecular response. And there are some similarities in the field of myeloma maintenance. Now, in terms of drugs, I'm not going to repeat what has been said by Dr. Frisola, but just to come to the reality as it is in Europe these days. Lenalidomide is not registered by the European Medicine Agency for maintenance treatment after autologous stem cell transplantation. Neither is bortezomib. So the question is, outside of the context of a clinical trial, what can we do these days? And taking into account that the aim is to prolong the time to progression. If we can, to prolong the overall survival, but not at the expense of unnecessary side effects or later resistant relapses. And especially with the novel drugs or the novel generation of drugs that will enter the clinic, we can't deny the economical impact of these treatments. So with thalidomide, and I'm not holding here a kind of a plea for saying now we should go back to the past about thalidomide maintenance, but the truth is that in many European countries, myeloma patients receive thalidomide maintenance after autologous stem cell transplantation. And the reason is, well, because there have been many studies done. And this is from the meta-analysis of these 6 studies, where you see that these studies showed an improvement in progression-free survival. On the other hand, it needs to be mentioned that these regimens, they were with different doses of thalidomide. Some of these studies thalidomide was given in association with low dose of corticoids. And in terms of improvement of response, for instance, going back to the French study, the improvement was only for patients not already achieving a VGPR. And these days, VGPR can be easily achieved with the current induction regimens, followed by autograft and eventually consolidation. But in terms of overall survival, the data were more heterogeneous. And especially the study done by Garrett Morgan and colleagues, the MRC study, showed that patients with unfavorable cytogenetics at time of diagnosis, and the type of FISH abnormalities are mentioned here. So these are the classical unfavorable cytogenetic abnormalities by FISH. that you can see here patients receiving maintenance treatment, their overall survival was worse compared to those who did not receive maintenance treatment with thalidomide. In other words, this is a strong argument in favor of the fact that in those high-risk patients, prolonged exposure to thalidomide can induce the emergence of resistant clones. And a second important point is that even in those patients that would qualify for thalidomide maintenance treatment, the treatment duration was very rarely longer than 1 year. The majority of patients received thalidomide exposure for around 6 to maximum 9 months. And in other words, maybe you can speak more of a kind of consolidation treatment rather than a true maintenance treatment. And the reason is that, as we know, that prolonged exposure to thalidomide is associated in the large majority of patients with the emergence of irreversible peripheral neuropathy, which can really ruin the quality of life of the patients for the rest of their life. So, to summarize the thalidomide part, in a real clinical life, it is used as a maintenance treatment, although one should speak more in terms of consolidation, and one should really be careful for patients with high-risk cytogenetics and monitor patients closely for neuropathy. So, lenalidomide, of course, is more active, and here is the simplistic cartoon about the tumoricidal and the immunomodulatory effect that is basically exploited in the maintenance setting. We have seen these data in the first presentation, the two studies that challenged a lot of debate at the myeloma workshop in Paris 4 years ago, where both studies with lenalidomide maintenance post-autograft compared to placebo showed a significant prolongation of progression-free survival, but in contrast to the US study by Phil McCartney, the French study by Michel Attal did not show a survival benefit. For the elderly patients, just to remind you, there is the MMO15 study, where most of the benefit indeed comes from prolonged or continuous treatment with lenalidomide, and the MPR is probably not the most ideal combination. And even in patients between or older than 75 years, these patients had a lot of toxicity from this combination. So a more elegant, continuous treatment in the elderly, as you have heard, is the combination of lenalidomide with low-dose dexamethasone, as nicely shown by Thierry Facon and co-workers. A couple of years ago, there was also a lot of talk about the second primary malignancies in patients being treated with lenalidomide. So, thanks to very detailed analysis, we have learned that this is only a minor increase in the risk, that this is particularly related to an increased risk for hematological malignancies, and that this can be narrowed to a small subgroup of patients that have been exposed to lenalidomide in combination with an alkylator like melphalan. But when you put all this into perspective of the chance of dying from myeloma, second primary malignancies are an issue but are not a major issue to worry too much about. We just need to monitor patients carefully and, if possible, avoid the combination of a drug like melphalan with lenalidomide. Bortezomib maintenance, well, there are not that many studies. I think the best study is the one that compared thalidomide with bortezomib once every 2 weeks. This was the HOVON study combined with the German myeloma study group. And yes, this study showed an improvement in overall survival in the bortezomib arm, but it was impossible to discriminate whether this was particularly related to the induction with bortezomib or to the maintenance with bortezomib or both. So this is still an open question. And finally, for the elderly patients, what is known about bortezomib maintenance? Well, this is also a study from Antonio Palumbo, where he compared VMP with VMPT plus VT, so bortezomib thalidomide maintenance. And at the last update of this study, it was showing that the VMPT-VT arm had a significantly prolonged survival compared with VMP. Although it needs to be mentioned that also in the very elderly patients, this VMPT regimen is not very well tolerated. So this is more a type of regimen for the fit elderly patients. We have heard nicely about the newer agents, and we await eagerly the data of these drugs in the maintenance setting. Of course, coming back to what Professor Anderson just mentioned, if we can go to an oral regimen with drugs that have a good tolerance and are very active, of course, this would be definitely the way to go in terms of maintenance treatment. So, of course, without any doubt, maintenance treatment is changing the paradigm of myeloma treatment. But we still need to find answers to several important questions. Which is the best drug? And probably which are the optimal combinations? And I fully agree with Professor Anderson that this will be probably drugs that exploit the immune system and give us the best, or give our patients the best benefit. Another question is, do we really need to give maintenance treatment to every patient? And then a final question still is, for how long? For a fixed period of time? Or do we give treatment driven by response assessment? So these are all open questions, and definitely the answers will follow in the next years. So this is the end of part one, and I mentioned earlier that I would just give you some advice on, or remind you about something that our country is very famous about, and this is the Belgian beer. So there are more than 300 different brands. This is one, and I'm pretty proud of it because it calls Grimbergen, and it's a small village, and I live in Grimbergen, and it's, you can find Grimbergen beer all over the world, and it's really one of the best beers. I'm not here to make kind of a promotional talk, but when I'm sitting at my desk at home, I see the Abbey of Grimbergen, and then when you have such a good beer and you reflect about maintenance, I think that is a good combination. Now, for the second 10 minutes of my presentation, I will talk about or supportive treatment. And of course, when I talk about this, I say, okay, this is the soft part of the presentation. But I think as a myeloma physician, I think, and I hope I do not need to convince you that it is very important. Because the symptoms of myeloma, they are still there. They are still there at diagnosis. By rapid, highly active myeloma regimens, we can alleviate these symptoms, but even at relapse, frequently these symptoms come back. So we need to talk most of the time about the drugs, about the way we handle the disease, but we should not forget about the symptoms that patients frequently suffer from. And of course, but due to time reasons, I cannot go too much into detail about drug-related side effects. But the longer patients live, the more we expose them to several types of drugs, the more we will need to take into account that some of these drugs might be associated with known or even some unforeseen side effects. So we need to remain vigilant. And secondly, the longer patients live, the more we need to do our best to make sure that they have a good quality of life. So, in other words, supportive care is of limited statistical significance, but of high clinical significance or relevance. So, briefly, what I will touch upon is just without giving an extensive talk about the management of bone disease, but just remind you about some of the important aspects of the management of myeloma-related bone disease. In order of importance, since 80% of the patients will present with some skeletal disease, then 30% or even a little bit more will present with some renal impairment. We should not forget that infections are very relevant in our myeloma clinic, and of course everybody of you knows how to deal with hypercalcemia and anemia. So skeletal disease in myeloma, just a general slide. We know it's there, we know it affects the axial skeleton. We know that is most frequently the initial presenting symptoms why patients are referred to our clinic. And this is a study from now nearly 20 years ago. This was a study from Ron Berenson comparing pamidronate with placebo, and it clearly showed that the administration of a bisphosphonate like pamidronate significantly reduced the skeletal-related events. Later on, zoledronic acid was introduced and it was registered, but this was based on a non-inferiority study. And this was a study including several types of cancers and also some myeloma patients. And you should keep in mind that at time of publication, that only very few patients in that study at the time of publication received zoledronic acid for a longer period of time than 1 year. But then the years have passed, and in our clinical practice we have learned that bisphosphonates are indispensable, but there was still this idea maybe the very potent aminobisphosphonate like zoledronic acid can do something more than just treating the bone disease. And this was particularly based on preclinical data that showed that, for instance, in mice with myeloma, that bisphosphonates on itself could kill myeloma cells. But a couple of years ago, there was this publication from the large MRC9 study that for the first time showed that zoledronic acid could improve the progression-free survival and even the overall survival compared to patients treated with a similar, who received a similar anti-myeloma treatment but received clofazimide as a bisphosphonate. So in 2015 we can still state that bisphosphonates remain essential in the treatment of patients with multiple myeloma, primarily to treat and to prevent skeletal-related events. All patients, also patients who do not have visible skeletal lesions on conventional X-rays, but who require anti-myeloma treatment, they should receive bisphosphonates. Zoledronic acid is in the majority of countries the bisphosphonate of choice because of the practical reason. The infusion time is only 15 minutes. Because of the fact that it is much more potent compared to pamidronate, at least based on in vitro data, and finally also supported by this MRC study showing that it has a positive impact also on progression-free and overall survival. It is given every 3 to 4 weeks, and then the question is for how long. But years ago, at the ASCO guidelines, it was mentioned you just give it continuously. It was a kind of maintenance treatment until there were the reports on osteonecrosis of the jaw. And then by consensus, it was stated, well, preferably not longer than 2 years. And patients achieving a complete remission without any skeletal-related events or without any severe bone pain, it is recommended to discontinue the treatment with bisphosphonates after 1 year. And I would be interested to know what you do at relapse. When a patient relapses and has new skeletal-related events, of course, you should reconsider starting again the bisphosphonates, but the question is, how long should you prolong the interval? For the time being, we do not have any data. And of course, we should not forget to monitor the renal function before each administration of zoledronic acid, and to take all necessary precautions to prevent osteonecrosis of the joint. Because for the time being, the incidence of ONG is still around 3 to 5%. Okay, so, but there is much more going on also for myeloma bone disease. And new agents will enter the clinic pretty soon. The first one is maybe denosumab. So the RANK ligand inhibitor that has already been used by our colleagues oncologists. But for the time being, we still wait for the randomized study that compares denosumab with zoledronic acid. Phase 2 study, or a study that has already been published, but just like with the initial registration study with zoledronic acid, that just pulled a whole set of tumors and compared denosumab with zoledronic acid, by surprise showed that patients with myeloma receiving denosumab, their outcome was not superior. Of course, this could be explained by several reasons, but this justifies why we need a phase 3 study to make sure that it will be a right decision to start myeloma patients a treatment with denosumab. Other interesting drugs are those that target DKK1, so BHQ 880, and then there is a drug sotatercept that targets activin A. So we will hear definitely much more about these compounds in the very near future. One should not forget that also some of the agents that we use these days can have a positive effect on the bone. And maybe the most important drug there is bortezomib. Although, again, not validated by prospective data, this is a post hoc analysis from the VISTA study, and there have been also many data coming particularly from Little Rock that have shown that a drug like bortezomib can stimulate also the osteoblasts. And this is just a slide from one of our own patients, where you can see here a large osteolytic lesion. This lesion was too large to be irradiated, but after 9 cycles of VMP, you see here nice bone healing. And sometimes it's worthwhile when you treat a patient with bortezomib to watch for the alkaline phosphatases. And in many patients, you will see in the first weeks of treatment an increase in alkaline phosphatases, which is frequently reflecting the anabolic effect on the bones. So 2 words about pain management. I mean, it's so straightforward, but I just want to remind you of that, because when you deal with myeloma patients, most of the time these patients will be in pain. And it's such a shame that frequently myeloma patients with pain are still undertreated. So there are many reasons why these patients have pain, and the primary reasons is, of course, the skeletal disease, which frequently necessitates the use of morphine analgesics, and of course then there can be other reasons for pain, like neuropathic pain with drugs like bortezomib. Even with a sub-Q and a once-weekly formulation, the incidence and the severity of neuropathic pain has significantly decreased. It's still there. And sometimes with the sub-Q administration, although it is rare, but it has been reported, we have also seen it in our own practice, there are patients that develop neuropathic pain after bortezomib discontinuation. So we need to watch carefully for neuropathic symptoms and act appropriately by primarily preventing that it gets worse. Because once it's there, in the past we have done a lot of work also with Paul Richardson on that topic, but once neuropathic pain is there, it's very hard to treat. We should not forget in the area of new drugs in myeloma that there is also radiotherapy that can prevent severe damage to the nerve system, radiotherapy that can also alleviate pain and prevent collapse of bones when there are extensive lesions. There is the possibility of vertebral or the more elegant technique of kyphoplasty, especially if painful vertebral collapses are there. Of course, there needs to be some conditions that the posterior vertebral wall needs to be intact. This technique is also not applied for cervical region, in the cervical region, but it is a very elegant technique to give immediate pain relief and to restore the stability of the vertebral spine. Renal disease, I'm not going to discuss it in detail, but again, there are many reasons why myeloma patients can have kidney failure, and we just need to make sure that we don't make it worse by giving the wrong type of antibiotics. We should give appropriate hydration and treat hypercalcemia promptly. We can talk half an hour about what is the optimal anti-myeloma drug combination for cast nephropathy, but for the time being, most data are in favor of the use of a bortezomib-based regimen. Although you don't hear me saying that you should not administer a lenalidomide-based regimen to patients with renal failure due to their myeloma, but you just need to adjust the dose appropriately of lenalidomide. And then finally, infections. Please keep in mind that in the first months of the myeloma treatment, infections are the highest or the most important or the leading cause of death. And in addition to that, they are also a major cause of morbidity and a significant contributor to the cost of myeloma treatment. Most of the time, these infections are caused by bacteria. And more rarely, these are viral infections, and exceptionally, especially these days when we use much less dexamethasone, fungal infections are very rare. But keep in mind that the risk factors are the high tumor burden, renal dysfunction, patients with severe skeletal disease, vertebral fractures, fractures of the ribs, they have hypoventilation. These are the ideal candidates to develop pneumonia or sepsis. We can do much more for the elderly patients, but also these patients have much more comorbidities or more vulnerable. And then, of course, some of the myeloma drugs, where I do not need to tell you that patients on proteasome inhibitors, for instance, need to receive prophylaxis with antiviral drugs. So again, I don't think that in an area where there are more and more resistant bacteria emerging, that we should put too many patients on standard prophylaxis with antibiotics, but we just have to remain very vigilant and inform the patients and the family doctors about the risk of severe infections. In some countries, like our countries, intravenous immunoglobulins are given to patients with very low IgG titers and developing severe infections. You could argue if that still makes sense. The studies date from a long time ago. And then the question about vaccination. It's important to try to vaccine or to give the vaccination against a pneumococcal infection at the time when the immune system is still capable of making enough antibodies. So this is my last slide. So multiple myeloma, without any doubt, it is a fascinating disease to deal with. It is a great disease in terms of treatment progress, but it is still a very symptomatic disease. And with the exception maybe for patients with acute leukemia during their acute phase. I think multiple myeloma within the hematological malignancies is still the most symptomatic disease, and we need to keep that in mind. So therefore, when we want to remain good myeloma physicians, we should keep a good knowledge about not only about the treatment, but also about the symptoms and the side effects of the anti-myeloma drugs. And in terms of symptomatic treatment, top priorities remain management of bone disease, prevention and treatment of infections, and preservation of the kidney function. And with this, I thank you for your attention.